This week's lecture will be reviewing Chapter 21, Vulnerability and Vulnerable Populations. This chapter begins on page 385 in your textbook, and it's Chapter 21. In starting and looking at this week's chapter, I've included the objectives, defining the terms that are included in this chapter. We're also going to look at, specifically within relationships terms, vulnerable populations and identifying groups that fall within this category. We're going to look at factors individuals and societies have that lead to the presence of vulnerable populations, examine ways in which public health efforts can positively impact the overall health of these groups, and looking at strategies that community health nurses can take to improve the health status of populations as well. Key terms to point out for this week's chapter are listed. Please pay special attention to these particular terms, and we will be reviewing some of them within the course of this content. Again, some of the information in this chapter will outline some of the information, some of the information in this PowerPoint will outline some of the information in this chapter, but some of the information in the PowerPoint will be supplemental information that will go along with and enhance the material in your text. So to get started, we're going to start with the definition of vulnerability. And again, definitions for this start on page 386 in your text. And with vulnerability, it looks at the susceptibility to negative events. And you'll notice that within this PowerPoint, it might not exactly be the exact terminology for your definitions that are written in the text, but they relate to more in common terms. So, for example, with vulnerability, it would be a person having biological limitations that are made worse by the environment. Something that makes them vulnerable, quote unquote, more at risk, or susceptible to having a negative outcome. Vulnerable populations, they are groups that have an increased risk to develop these adverse health outcomes. Then we have the term risk, referred to as some people have a higher probability of illness than others do. And these risks can be modifiable or non-modifiable, in the sense that risks can obviously be non-modifiable for the fact they could be genetic or biological. We also have modifiable in the sense that they could be risks that are based on income, environment, etc., potentially factors that could be changed if the right assistance was in place. Then we also have cumulative risk. And cumulative risk is the additive effects of multiple risk factors. And with this, I reference the web of causation. And web of causation means that if you think of it in relationship to a spider web, you have many different causes for different risks or different effects. And the web of causations mean there's multiple things that culminate together to create or enhance that risk. We also have the term for resilience. And it's the ability to withstand many forms of stress and deal with several problems simultaneously without developing health problems. And I think the most common thing that we think of when we think of resilience, for example, would be the immune system. Some people are resistant to illnesses and the cold bugs or the flu bugs or things like that, but we all know that we have certain factors such as stress that can decrease our resilience or decrease our ability for fighting those things off. The next term references health disparities. And health disparities refers to the wide variations in health services and health status among certain population groups. And so basically it's looking at disparities, meaning the different levels of health among certain populations. And this can also be not just health, but also health services. And they're basically that there's a disparity or an uneven amount that's available to certain populations. And then going along with that, we have disadvantage, which are those who lack adequate resources that other people may take for granted or customarily routinely have them available to them. For health disparities, we look primarily at the areas of health disparities in relationship to infant mortality, childhood immunization rates, and disease-specific mortality rates. As I've mentioned in previous lectures, infant mortality is an issue that has come to the forefront within the state of Wisconsin, as we do have a fairly high infant mortality rate, specifically within 5 local towns or counties within the state of Wisconsin. Milwaukee, Racine, Beloit, Dane County, to name a few. And with that, we're looking specifically at the health disparity in relationship to infant mortality, noting that there is a disparity for African Americans. And our infant mortality rate consistently across the board runs highest in African Americans within the state of Wisconsin. Also looking at childhood immunization rates, there's definitely health disparities based on race and ethnicity for the number of children who are actually up to date with their immunizations. And then we also have disease-specific mortality rates, where we look at things related to heart disease, for example. Typically have health disparities where African Americans are more affected by heart disease. And some factors that can influence the health disparities can be poverty. With that, maybe they're not eligible for services, or they don't have access to services. Also, low education. And in relationship to low education, you have to think of things such as health literacy and making sure that health information is at an acceptable level where people can understand the information that's being given to them. And it is questionable about race and ethnicity as well, if this really does influence health disparities, or if it's other factors in combination, or if it just happens to be circumstance. So who's included in vulnerable populations? And if you review your text on page 386, it begins with the definition of vulnerable populations. And it talks about those that are vulnerable in relationship to certain health problems more than others. It also then goes into different terms, talking about cumulative risk, resilience, and health disparities, which were mentioned, and then goes into looking at disadvantaged. Some of the vulnerable populations that we can consider are the poor and the homeless, pregnant adolescents, migrant workers and immigrants, severely mentally ill individuals, alcohol or substance abusers, abused individuals and victims of violence, persons with communicable disease and those at risk, and persons with HIV, hepatitis B, or STDs. And this box is actually indicated, and I do apologize. I see that I just made an error. Ooh, and I see that I just had a pop-up. Sorry. Bear with me here, students. I am so sorry. Okay, we should be back on task. Reviewing that last slide, I do see that I have an error. 387 is box 21-1 that outlines these populations that have been identified. And you can see on that same page that the goals for Healthy People 2010 are listed in relationship to vulnerable populations as well. So we also then start to look at some predisposing factors, which are on page 388 in your text. And it does mention things like income, which we mentioned, and that's specifically in relationship to the poverty rate. We also go on to look at physiological conditions and life experiences. So looking at some of those vulnerable populations, we have the elderly. And in the last census that we have statistics for in 2000, it shows that the median income of people over the age of 65 is less than $14,000. You can see that there is a significant difference between males and females, and that almost 34% reported income of less than $10,000 per year annually. Now, if you think about that in relationship to rent or mortgage, utilities, not to mention medical bills, medication, insurance, multiple things, $10,000 a year is not very much to live off of. So unfortunately, we do have a population that is getting elderly, and as we all know, the baby boomer generation is the largest population, and they are progressing into the elderly phase. And we're going to see more and more elderly who cannot afford to take care of themselves. And what we will see then, unfortunately, is more elderly who qualify for more services such as not only Medicare, but also Medicaid. And sadly enough, with that along comes elder abuse. And specifically looking at the areas of physical abuse, psychological abuse, financial, and social abuse. And physical, I think is self-explanatory. Psychological is just basically mental or emotional abuse that individuals can play on the elderly. Financial abuse is someone financially taking advantage of an elderly person, and this could either be family members or a caregiver. And then socially, unfortunately socially we have a stigma where in the United States elderly people are a little bit more easily discarded, should we say, and kind of frowned upon as being wanted members of society or appreciated members of society, and that does play into the overall feelings of appreciation and acceptance into the population, which sometimes then can lead to social isolation and hence social abuse. Within the elderly rate, we also see a high incidence rate of suicide, and a lot of times it's caused by chronic illnesses, physical impairments or pain that they have, financial stress, and you can see in the previous slides how that easily could relate, and oftentimes with the physical conditions and the financial issues, they tend to start to feel more like they're a burden on their family members, and so they believe that this is going to be an easier solution for their family. We also have issues related to social isolation and loss and grief, and then also alcoholism, which unfortunately is often a result of the two above. Warning signs of suicide, I will let you go through this slide yourself. This is certainly in your handout, and it is important as a nurse for you to be familiar with these warning signs. Particularly in the elderly, you will see them start to get their things in order, quote unquote. They will start to give things away. They will start to kind of organize things. They'll start to write things down or say, if this happens, I want you to, blah, blah, blah. They'll start to express certain feelings, or they will say they feel hopeless, worthless. They might start to say things too like, don't worry about me, or, oh, I don't want to be a burden. They'll start breaking their medical regimens, which for elderly is usually quite a social experience. Typically, they know when their doctor's appointments are, so that's typically one of the last things that they skip. They'll start to break those appointments or skip them. They'll start to make changes in their day-to-day activities. The main thing to focus on too is if you notice that there's a stockpiling of medication or any other type of lethal means. Certainly warning signs you want to be very concerned about and report as soon as possible. And the role of the community health nurse is to be knowledgeable of services that are available to these different populations. With that, being proactive in designing different interventions to help. Make sure that you're designing and doing education based around healthy lifestyles, good nutrition, physical fitness, emotional health, safety, promoting independence. Ultimately, with your elderly, promoting independence is one of the main things that you want to focus on, and this not only can be done from assistance with the nurse, but certainly referring out to other agencies, services, groups in the community that can provide support and services to this elderly population. We also look at the population of the mentally ill. And mental illness is prevalent in all segments of society. In the United States alone, there's 23 million non-institutionalized adults who have different types of mental disorder. And there's many people who are in community populations that live in substandard housing and have difficulty maintaining themselves. And this is simply a result for the fact that they don't have the resources and they just so happen to be a non-institutionalized adult, but need obviously more services than what they are receiving, if any. Of the 4 million people in the United States who have a severe mental illness, 900,000 live in institutions and the rest live in the community. So as you can see, mental health is a need. Unfortunately, mental health services are typically one of the hardest types of services to provide for many different reasons. Oftentimes, mental illness for the poor is very difficult to find. Multiple reasons: cost, access, simple things like reimbursement rate, having enough qualified providers, not just counselors, but also actual medical personnel who can prescribe and monitor medications, so a psychologist, and then also having these people that are available within a particular or desirable distance for the population. So typically finding them within an urban setting. Even more difficult is within the rural setting. And along with that comes concerns about privacy and perception and people not wanting to know or having others know that they are seeking mental health services. That is always of great concern. So basically privacy issues. Factors that contribute to this are continuing deinstitutionalization, so unfortunately chronically mentally ill people being pushed out of institutions into the community, reducing hospital admissions, and then also fewer days that are spent in the hospital. Deinstitutionalization is, as I mentioned, moving clients from institutional care into the community setting. Typically, this is related, unfortunately, to financial cost. It's obviously much more cheaper to provide mental health services in an outpatient setting. However, it's not necessarily the most conducive form of therapy for someone who's mentally ill and has consistent difficulty functioning on a day-to-day basis. They need a familiar environment. They need triggers. They need cues. They need focus. They need repetition. They need support. And these are typically things that go by the wayside if they're left in an environment where they have to manage some of those things themselves. Failure factors in relationship to deinstitutionalization, we see inadequate transition services, meaning that there's not enough follow-up or follow-up doesn't happen for long enough, or the fact that they're literally just taken out of an institutionalized setting and let go and turned over on the street. Typically there's coordination between the staff with the client to get them transferred to some type of external living environment. However, there's not necessarily that continued follow-through as mentioned. And placement in unsupervised settings, specifically placement in apartment complexes, etc., that are not set up for those who are mentally ill. Lack of education and or support for family members. Again, this puts a tremendous burden back on the family who are expected to take care of their loved ones. And lack of education for community agency staff. Unfortunately, a lot of times within community settings, particularly like community-based residential facilities or assisted living complexes related to mental health services, you often have minimally trained, very low-paid staff, which means that you have a turnover, you have lack of appreciation or motivation in your job. You also have, unfortunately, individuals who aren't always most qualified in working with this population. So listed for you are goals for your vulnerable population, and again, this was mentioned in your textbook, so I will let you refer to that. Continuing with definitions, again, we look at disenfranchisement, and it's the sense of social isolation, a feeling of separation from mainstream society. So individuals who just are not fitting into society and basically the route or path of how things are going. Vulnerable populations at risk related to weak social supports, weak links to community organizations, and few community resources. Predisposing factors for this include socioeconomic status, so low income or lack of insurance. They can't get the resources that they need. They can't keep up with the type of medical care that everyone else is getting or the type of living style that everyone is accustomed to. Age-related causes, health-related causes, and also life experiences. Outcomes of vulnerability are all linked. We have poor health outcomes, which unfortunately typically then results in chronic stress. And with that chronic stress becomes increased sense of hopelessness. And with that, the cycle starts all over again, where if you have that increased hopelessness, you have poor health outcomes. I'm just going to have to pause this for one moment, class. Right, thank you, class. So looking again at these outcomes, for vulnerability, we look at basically a cyclical pattern beginning here, where the poor outcomes affect the stress level, which affects the feelings of hopelessness, which unfortunately relates back to the chronic stress, which relates back to the poor health outcomes, and unfortunately becomes a very vicious cycle. I do want to point out for you, in your text, on page 393, we have levels of prevention related to vulnerable populations, so looking at primary, secondary, and tertiary preventions. We also have assessment issues, and so this is particularly enlightening for nurses who work with vulnerable populations and the fact that they need good assessment skills, particularly outlining on page 394 how to assess members of this population. And I think this is important to point out that there's multiple facets of this, looking at setting the stage, nursing history of not just an individual, but also potentially of a family, and then a physical examination, or potentially also the home assessment. And those are all very key components. Planning and implementation of care of the vulnerable population, that is outlined on page 395 on your text, and it goes through each of these 5 areas, basically saying, and there is the how-to box on page 396 as well, basically stating that you will have different aspects that you need to look at, and these are referred to as key nursing actions that need to be used. You need to create a trusting environment. You need to show respect, compassion, and concern. Do not make assumptions, which unfortunately is very easy for us to do, particularly based on our past interactions or encounters with individual representatives of that population. Coordinate services and providers, and advocate for accessible health care services. And we have to remember, particularly with vulnerable populations, sometimes it's hard enough just for them to get through the appointment, let alone maneuver through the healthcare system, which we all know can be quite tricky. So we do need to make this as conducive as possible for them to seek care and to continue with it. Continuing with that, we also need to focus on prevention. Know when to walk beside and when to encourage clients to walk ahead. This can be a particularly difficult area to focus on for nurses, particularly someone that might be new to the area of community or public health. Reason being is, I think oftentimes within the hospital setting we are very used to specific guidelines of what you need to do for the patient, and then you educating the patient on what they need to do for themselves. And that's specifically in relationship to discharge. But oftentimes within the specialty of public health, we have to look at educating the client on what they need to do for themselves and giving them the resources to be able to do that. So taking a step back and not following through those things for the client ourselves, but giving them the tools to be able to do it, because we always have to look from the aspect of what is the client going to be able to do if the nurse is not there. Number 8, know what resources are available. It's very important for public health staff to keep up to date on resources that are available. These are resources that you typically should be referring your clients to on a very regular basis. Developing your own support network, and then also knowing oneself. It's very important also for us to look at our own self and know our feelings about working with populations, about how we feel about populations, if we're giving them the best of what we can give, if we internally have any issues that we need to deal with as far as feelings of racism or exclusion, making sure that we as a blank slate can be neutral to serving any of these clients that we may come in contact with. So to review the chapter, I would like to point out a couple different questions that we're going to review here. To summarize really quickly, too, this goes through some of the key terms that we've already reviewed in the chapter. So question 1. An urban city uses the local media and local newspaper to post ratings of air quality on days when the air quality is poor. This notification is directed toward the elderly, the very young, and those with chronic breathing problems. These groups are an example of which of the following? Would they be disenfranchised population, disadvantaged populations, vulnerability, or vulnerable populations? Now I know this is an easy one, class. You're going to get this without any difficulty. And the answer is vulnerable populations. And again, referring back to the definition, is those who have an increased risk of developing poor outcomes. With this particular one, these were individuals who are already at risk for respiratory problems. Question number 2. Health education is often used as a strategy in working with vulnerable populations. A group's or individual's benefits of health education can be affected greatly by which of the following? Cycle of dependency, health literacy, level of income, or race and ethnicity. And the answer is B, health literacy. And as I've referenced before, it's very important that when we educate clients, we are consistently educating, and I believe what's recommended right now is currently a 4th grade reading level. This obviously will vary depending on certain ethnic groups. For example, Hispanic populations, specifically ones who have recently come from another country, typically have a lower literacy rate simply because of the time that they have gone to school. You will often find that they typically go to school for a shorter time period than Americans do, and particularly within that, it's very common to have females who go to school for even less period of time. So oftentimes you may have a female who only went to 4th grade. So if she went to 4th grade, unfortunately she's not going to have a 4th grade reading level. It's probably going to be even lower. And we also have to remember that that might be a 2nd to 4th grade reading level in her primary language. Looking at reading it in Spanish. Now imagine reading that in a secondary language, it certainly would be even lower. So things like that we need to take into consideration. So it's always a good idea not just to give written materials, but review the written materials, verbally explain. If you can give any information with pictures, also if you can talk it out, and demonstration always works very appropriately. Question number 3. A poor elderly Native American woman lives in a small remote village near the Canadian border. She has been diagnosed with hypertension and diabetes, but rarely makes it to the regional clinic in a distant town for checkups. This woman is most at risk for which of the following? Disenfranchisement, health disparities, loss of independence, or resilience. Now, this one might be a tricky one, but I'm sure you can get it. The answer is B, health disparities. Now, some of you may have chosen disenfranchisement, which is a sense of social isolation. And that very well could be, but unfortunately in that question, it didn't say anywhere that she was experiencing a sense of social isolation. But health disparities is the proper answer because, again, that definition looks at the wide variations in health services and health status among certain population groups. And if we revisit that question, it states that she lives in a small remote village. She's been diagnosed with chronic health problems, but rarely is able to make it to the clinic in a distant town. So again, this is a health disparity because most of these aspects seem to be out of her control based on her physical environment. And question number 4. A young adult with a history of prior parental abuse has recently been diagnosed with a stress-related illness. The individual works at a local convenience store, earning a little more than a federal poverty level, but receives no health benefits. This individual is predisposed to the development of which of the following? Is it poverty, resilience, risk, or vulnerability? And the answer is D, vulnerability. And again, the definition stated is results from the interaction of internal and external factors that cause a person to be susceptible to poor health. If we go back and look at the other multiple choice answers, poverty is lacking resources, which certainly in looking at that, you can kind of assume that she is, but it doesn't specifically state that, but it does indicate that she's just above the federal poverty level. Looking at resilience, actually that would be very inappropriate because anything most likely she probably lacks resilience. So she'd be predisposed to poor resilience or low resilience. Risk, the likelihood that some event or outcome will occur. She has some predisposing factors, but we can't really indicate that she's at risk per se for any one particular thing. So essentially, again with this, she's considered vulnerable. And again, that definition results from the interaction of internal and external factors that cause a person to be susceptible to poor health. And it states that she has stress-related illnesses. She obviously has a prior history with abuse. She is just above the federal poverty level. So all of those things make her predisposed to being vulnerable. So finishing up class within this chapter, I'd like to refer you back also to review page 397 in your text. There's a couple interesting how-to boxes and graphs that spell out case management for vulnerable populations. Also using case management and working with vulnerable populations. Also on page 398, there's a very good clinical application that I refer you to. And then again, just remembers this for the chapter. If you have any questions on this week's content, please do not hesitate to contact me. Otherwise, I think it's spelled out very nicely, in this week's chapter. Thank you, class.